Chief complaint. In this case, we have a 56-year-old male who complains of headaches, jaw pain, and popping of the jaw. He believes his symptoms began in 2012 when he was involved in a car accident. He states he has no direct trauma to the jaw from the accident, but that he braced himself and clenched his teeth together just prior to the crash. He saw an orthopedist and was referred for physical therapy. The physical therapy did reduce the headaches. The report of the brain CT without contrast taken after the accident stated that there was no obvious pathology. He stated that he could be pursuing a work comp lawsuit due to the car accident, so he was not sure if he would switch doctors. History of present illness. So this began in 2012. He believes the causation was from the auto accident. The pain is in the right and left jaw. The type of pain is sharp and achy. The frequency is 1 to 2 times per week. The attack duration is 2 seconds. The severity is moderate. What makes it better, he's not sure, and he's not sure what makes it worse. He has 2 different types of headache. Headache number 1 started a few weeks after the accident. The quality of the pain was pulsating, and he noticed light sensitivity. The frequency of this type of headache was once per month, and the severity was 9 to 10 out of 10. The headache would last 48 hours. It would feel better in the darkness, and Advil also helped a little. What made the headaches worse was light. Headache number 2. The headache started in February 2012. Causation unknown. Location bilateral temporalis radiating. The pain was more of a pressure pain, and this was more of a daily type of pain. It would last hours, and the severity is more mild to moderate. What would make the headache better was physical therapy, and he doesn't know what made it worse. Medical history. His medical history is positive for hypertension, heart attack, diabetes type 2, asthma, headaches, and oral herpes. He has an allergy to Dilantin as well. He's taken multiple medications listed here for his heart disease and for his type 2 diabetes. Doing the extraoral exam, the palpation of the craniofacial muscles showed right-left masseter moderate pain with insertion of the mandible, and it refers to the chin. The left masseter was moderate pain. The right posterior temporalis was mild pain. Left posterior temporalis was moderate pain. The right temporalis tendon was moderate, and the left temporalis tendon was mild. And the right SCM was also mild. The palpation of the joint revealed right lateral condyle mild, right dorsal condyle mild. The lateral left condyle was moderate, as well as the left dorsal condyle. The max pain-free open was 55 millimeters, which is normal. Right-left lateral max was 10 plus millimeters, which is normal. Overbite and overjet 2 millimeters, and no joint noises were detected today. The intraoral exam showed normal posterior contact with mylar, normal occlusion class 1. He did have some scalloping of the tongue. Number 6 was in cross-white, and he had light wear on the second molars. And his salivary gland function was normal. We took a panoramic image, and everything was in normal limits within the panoramic image. For the assessment, I diagnosed myofascial pain, capsulitis, sleep disorder, tension-type headaches, migraines without aura. For the treatment plan, number 1, myofascial protocol, avoidance protocol, end position, end stretch, thermal therapy, and a handout was given. Number 2, the patient stated he already is taking quite a few medications for his heart and diabetes and did not want to have any more medications if possible. So I prescribed Voltaren gel, 100 grams, applied to TMJ 4 times a day. Patient would like to avoid systemic medications if possible, as I mentioned. So this topical medication would be our first-line treatment. Patient has an appointment with the sleep evaluation this evening. Request a copy of the sleep study. I recommended a night guard for this patient. Patient aware of possible future TMJ, MRI, TMJ, steroid injection, trigger point injection, or arthrocentesis if conservative treatment does not help this patient. I also wanted to request a copy of the orthopedic report. I will reevaluate the headaches when the TMD symptoms subside and the possible future neurologic consult. Patient to return in 3 weeks to evaluate their symptoms. We spoke with the patient on the phone, and the patient stated that he was doing a little bit better, but that he was going to be involved in a work comp lawsuit and he would need to see a different doctor for this case. Well, what is the myofascial protocol we've been discussing? Well, number 1, avoidance protocol. There's functional avoidance, parafunctional avoidance, posture, habit avoidance. So opening wide, for example, could be difficult on the joint if it's already hurting when opening wide. So yawning, big cheeseburgers should be avoided, biting into big apples, gum chewing, habits like biting your teeth, biting pencils, pens. Posture is also very important. A lot of us work on computers these days, and our posture can be affected by this if we're not really consciously focusing on our forward neck position and having good posture. Also in the myofascial protocol, thermal therapy is important with the use of hot or cold packs depending on the situation. There's a variety of different types of hot and cold packs that are on the market. We have the reusable hot-cold packs that can be placed in the microwave or in the freezer. We also have microwavable, freezable cloth type. There's head wraps available for the muscles of mastication, which is very helpful. And then those instant cold packs we have as well that can be broken and cold in an instant. The types of stretching that are available to patients for TMJ issues would be assisted jaw opening, hinge exercise, neck exercises, and in this case we prescribed end stretch. And the end stretch is where we take the tip of the tongue to the roof of the mouth and open to approximately 2 inches. And we hold that for 5 seconds, 5 sets, 5 times a day. Well, what does the research say about conservative treatment? There was a systematic review done by De Freitas, investigated the effectiveness of counseling and other self-management-based therapies on muscle and temporomandibular joint pain relief and increasing functional abilities of patients with temporomandibular disorders. Counseling and self-care include counseling and self-care approaches which were education about the disease and assurance of its benign course associated with the use of heat and cold packs, jaw exercises, and guidance regarding reduction of parafunctional activities, progressive muscle relaxation, diaphragmatic breathing, and improving sleep and posture. The article analyzed revealed that counseling was able to improve tenderness upon masticatory ambulatory muscle palpation and maximum mouth opening, with and without pain in patients with TMD, and with similar results to those of interocclusal appliance approaches. So conservative treatment can be very effective and should always be our first attempt when treating a patient.